Yeah.
Wait. Okay, so we are live.
Yeah. Hello, everyone. I welcome back all of you to this continuous sessions on Fertility Masterclass. I know we took a break in between, and in between, I think I was in a hangover of TOT, which Dr. J put in Bangalore. I'm still recovering even after 120 hours. So I think the versatility is, I think it's there more to explore for all of us. And today we'll be talking about the immunology in reproduction. And this is one of, I think, one of the most relevant players in the field of reproduction, which is coming up more and more because of the research that is happening in this field. And because of the advances that has happened in recurrent implantation failures and also in recurrent miscarriages, I think this is one topic which everybody would like to definitely know, and the practical tips involved in it. And the basics of it is extremely important for us to know practically how to deal with the clinical situations. And that is what Dr. Jay is going to speak today. Yeah, over to you, sir.
Hi, friends. So I just want to tell you one thing. This is a science where nobody knows many things about it. Okay, so that is the first point. Remember, multiple therapeutic approaches have been suggested. For example, you can give steroids, you can do hysteroscopy to rule out endometritis, you can give intralipids. Actually, intralipids is nothing but parenteral nutrition. Okay, you can also give IV immunoglobulin in some patients. It is an expensive therapy. Some people also like to do fancy things like LIT. Some people will do many things. Understanding? But please remember one thing. You cannot do, unless you are a commercial clinic, okay, you cannot do LIT for a single abortion. You cannot do LIT for a single biochemical pregnancy. Okay, you cannot do LIT, or you cannot do intravenous lipids, or you cannot do IV immunoglobulin if the patient has had a single abortion. All such things are made up for commercial purposes. So this lecture series is not going to discuss any commercial indications for anything. Okay, this is only going to discuss where you should do what, and just in case you want to offer some sensible guidance to your patients regarding this, understand it first, and then you can guide, or you can even prevent your patients from doing some nonsensical things. Okay, so first, this session will only cover the basics of reproductive immunology, and I will try to finish it in 15 minutes time. It's a huge chapter, but from whatever little I have understood or whatever little I know about this, I have been practicing reproductive immunology over the past 4 years, and we've been doing LIT, we've been doing IVIG, intralipids, hysteroscopy, IHC studies. We have our own genetic laboratory, so we've been doing all of that since quite some time. So I will just share the screen and share my experience on this entire thing. And let me tell you, this is an ever expanding science. Probably 6 months down the line, if I take a session, I might give some more inputs and I might tell you that this is wrong or this is right again. All right. But the reproductive basics is never going to change. All right. So let me just share the screen. Shilpa madam, just let me know if you can watch my screen.
Yes.
It's watchable, no?
Yes.
Okay, fine. Can you see this? Fine.
Yes.
So we are going to be discussing just the basics of reproductive immunology. All right. And as a doctor or as a patient, now multiple of our patients are also watching these videos. It is important for you to understand that if I try to talk about pregnancy, see, pregnancy is not a disease. Okay, pregnancy is basically a state where a semi-allogenic graft. What is the meaning of a semi-allogenic graft? Okay, this is a hi-fi term. The simple term for that is fetus. Okay, why are we calling it a semi-allogenic graft? Because female partner, male partner, their combination is actually the fetus, which I'm just drawing as a blastocyst embryo right now. Okay, and this is going to get implanted inside the female. So 50% of the component is going to get derived from the male. So it is not completely autologous, and it is not completely allogenic also. Complete allogenic means 100% is derived. Complete autologous is 100% is coming only from the female. No, all uh, uh, female NGOs want only that, no? Baby should come only from the female, male is not eliminated, this, that. But currently, God does not want it that way. Okay, God wants it as semi-allogenic only. And that is why pregnancy is a beautiful thing. See, in a semi-allogenic graft, pregnancy allows this semi-allogenic guy to grow in size, okay, go up till the reproductive potential of approximately 9 cycles during the entire obstetric window, and then deliver. Okay, so in this entire state, this embryo is basically going to go inside the uterus. Okay, there we have the endometrium, and here you have the embryo. Okay, here you have the embryo. So, what is basically implantation? As we all know, in implantation, if I magnify what is going to happen here, if I magnify this entire implantation ka cheese for everyone, see, we will have something like this. Okay, so we will have this embryo here. Now remember one thing very, very important. Embryo has two components, right? One is an inner cell mass and then is the outer cell mass. Correct? The outer cell mass is also what we call as the trophectoderm. Okay? This is the trophectoderm. Trophectoderm. Okay? And it is the trophectoderm cells which are going to form all the syncytio trophoblast. Okay, so this is the region where all these cells will keep on expanding, okay, to form the syncytio trophoblast. With syncytio trophoblast is actually going to go and form the future of the placenta. Correct? And there comes the uterus. Now, what happens inside all of this is somewhere here you have these uterine vessel here, and from the uterine vessel you have nice beautiful spiral arterioles which have come. Okay, these spiral arterioles are like super dense, okay, because they want implantation to occur. Okay, and reproductive immunology is something which focuses on all of this at the molecular level. So basically what happens at the molecular level is very simple. It is only the trophectoderm which comes and interacts with the mother, with the maternal cells. Okay, there is otherwise a barrier. Placenta is otherwise a barrier between the fetus and the maternal circulation. Correct? But it is not completely like that. You know, some of these cells which are present here, no. Some of these syncytial trophoblast will come up till here. Some fetal cells will cross the circulation, and some of these things, some of these cells which have crossed the circulation will also come inside all these things. But there are, apart from all these structures, a large amount of immune cells which are located here. In fact, if I ever study the uterus at the time of pregnancy, and this has been documented, so this is not something which I am documenting, this has been documented multiple times, that if I look at all these immune cells which are present, okay, here in the uterus, these immune cells typically consist of uterine NK cells. NK means natural killer. Oh, what a name, nahi? Natural killer cells. But natural killer cells are actually not going to kill anybody. Just remember that. That is a misnomer. Okay. Around 70% or probably 60% of the cells are natural killer cells. You also have macrophages, which are present in the immune. It's a very important function. Macrophages around 20%. Okay. Then you have T cells. What is T cells? What is this T actually? T is for something called as thymus derived cells. Okay, thymus. So thymus is a gland in the body. These are actually T cells are derived from the thymus, and based on this, there is a beautiful product which is called as thymosin alpha, which is available. So I'm going to be talking about that in a later class. Okay, so these T cells are going to comprise of approximately, let's say, 10 to 15%, and you have very small quantity of B cells also. Okay, B cells will come from the bone marrow. Okay, so what is important to understand is you need a good concentration of natural killer cells, you need good macrophages, you need good T cells, and you need good B cells in order to ensure that this interaction which is happening between these two people, okay, the interaction which is going to happen from the fetus and the interaction which is going to happen on the reverse direction, this is kept intact. Okay, now again, very important to understand that this concentration of the natural killer cells, the concentration of the macrophages, and the concentration of T cells can vary based on number of functions. But at the moment, what is important for us to understand, and I will just magnify this even further, for all of us to now understand it. I'm probably trying to go into some molecular level, but I will not go into molecular level for more than 2 or 3 minutes. Okay. So this is a molecular understanding just for us. Okay. Just for all of us to understand what we are trying to deal with in this entire subject. Okay. So I mentioned these 4 types of cells. As I said, NK cells are going to form the priority. They are going to be very, very important. So I will just draw the fetus now little large. Okay. You have a large fetus. Let's assume, this is the inner cell mass here. Okay. And this inner cell mass is the one which is going to give rise to the fetus. This is your trophoblast here. Okay. This gets embedded and this gets covered. Okay. By the syncytial trophoblast. So we already know that syncytial trophoblast is going to form a lot of the placenta. Okay. And then you have the maternal bed also. So this maternal bed, I will honestly just draw as arteries. Okay. This is the maternal bed. And inside this maternal bed, we are aware, no? That inside this maternal bed there will be invasion of syncytial trophoblast. We already know these things, so there is no rocket science. Okay. So now what is going to happen is that if you have a good amount of uterine natural killer cells in an adequate concentration which is present here at this early stage of implantation. Okay, at early implantation, if you have adequate amount of immune response, okay, this immune response is modulated by the natural killer cells in such a way, okay, the NK cells will modulate the response in such a way that it increases vascular endothelial growth factor, it increases matrix metalloproteinases, and it increases all oxidative molecules. Simultaneously, it will also increase all the good cytokines. Okay. And this is the function of the natural killer cells. When does this function of natural killer cells get affected? Commonest is infection. Second is injury. Third is immunocompromise. And fourth is drugs. So basically, these NK cells are going to get compromised when you have uterine infection, when you have uterine injury, when you have an immunocompromise, or when you are under some influence of drugs. In all those situations, vascular endothelial growth factor, matrix metalloproteinases, and good amount of cytokines will be downregulated by the same NK cells. Okay, which gives rise to an altered immune response. And as a result of which, the normal immune response, which allows for a great early implantation, gets disordered, and it gives rise to formation of recurrent implantation failure, and it gives rise to early abortions. Correct? Now, if you understand this one slide without looking into the further micro details, acha, how will you mark NK cells? How will you mark any other cells? There are multiple tests available. I will be discussing CD56. I will be discussing CD138. I will be discussing MUM1 and all these tests which are available in my future sessions on this, because these are simple tests which you can do in-house. Okay. But if you understand this, then it will come to your mind that recurrent implantation failure or recurrent loss of early pregnancy, okay, which we are trying to continuously debate about. So when we are trying to debate about these two things, is heavily dependent on infections, is heavily dependent on injury, is heavily dependent on immunocompromise, and it is heavily dependent on drugs. Before we call anything as idiopathic, okay, it is important that we understand that 60 to 80% of compromise is going to happen due to abnormal NK cells. Okay, and these abnormal NK cells will contribute to a lot. For example, our all therapies which we look at, like for example, IV immunoglobulin, if we look at intralipid, both these therapies will try to address the NK cells. If we try to look at lymphocyte immunization therapy, which is paternal lymphocyte immunization therapy, it predominantly looks at the T cell response. As a result of which, LIT is considered to be one of the least effective, or it will work in only 10% of the cases. Intralipids, IVIG, Vizolone, which we also called as prednisolone, effect in more than 60 to 80% of the situations, as a result of which you may have slightly better outcomes with that. But to diagnose all of these things, you need to be very good at doing hysteroscopy. And looking at a good hysteroscopic picture is going to be very important when you try to understand endometritis in any manner. All right. Apart from this, please try and understand, because it is an immune response of pregnancy. Okay. Because it is an immune response of pregnancy, immune response in pregnancy is also modulated by two important people. And this is something which majority of the people don't know. And these two important people are estrogen and progesterone. These hormones are really upregulated when a person is pregnant. And because these hormones are upregulated when a person is pregnant, they also contribute to a severe modulation, immune response modulation, which is so important for pregnancy to continue. And as a result of which comes in the role of using good amount of progesterone or using the right progesterone in order to ensure reduction in implantation failure, in order to ensure reduction in an early abortion. And finally, before I conclude all these things, please remember, all this is going to be effective only when this gentleman, embryo, is actually a nice guy. Okay, if this embryo is actually a euploid embryo, okay, that is a chromosomally euploid embryo, only then all this is going to be nice and effective. In cases of an aneuploid embryo, no matter what you do, there are some amount of fetal cells, okay, which will enter inside the circulation. And these fetal cells will ensure and tell the body that it is an aneuploid embryo. Immune response will be altered, and nature or the body will try to reject this semi allogenic graft. And as a result of which, an abnormal embryo has a higher shot of getting aborted. Okay. This is the absolute basics, okay, which as clinicians we need to understand, because when you understand this entire topic as a clinician rather than understanding it as a scientist, you will be only be able to pinpoint and look at the things which you need to look at rather than worrying about more molecular level things. More molecular level things we will look into when I go into the molecular aspect of it. I'll take some lectures on it. I'll show you how the slides and everything is made in this thing, because it's very easy to show you. Okay. And we will look into it in greater details. So with this, I conclude. I think if Shilpa madam has one or two questions, then maybe I can answer.
No, I think yeah. So in all this, like what you are saying with regard to the CD cells and the NK cells and all that. So what is your take on the T helper cells 1, T helper cells 2? What about the pro-inflammatory and anti-inflammatory part of it? Is it like the immune system of the mother needs to be suppressed enough for the acceptance of the fetal graft? I mean, what is your concept on all this?
So the immune system of mother is never going to be suppressed. The immune system of the mother is always going to be altered. That is the important word to use, because otherwise a mother who is immunosuppressed is going to have a higher chance of becoming pregnant any which ways. You will not have to do any therapy. So for example, post-transplant patients who are any which ways immunosuppressed should have excellent pregnancy outcomes. It is not correct. The immune response is altered. And because we exactly don't know where the immune response is getting altered, all right. Nobody knows at the moment how much T helper 1 versus T helper 2 ratio is required. Nobody knows how much NK cell ratio is required. No, I'm talking of uterine NK cells, right? Nobody knows the ratio of peripheral to uterine NK cells which you require for a successful pregnancy. As a result of which, all therapies which we try, immunoglobulin, intralipid, Vizolone, and lymphocyte immunization therapy, all these four therapies are considered to be experimental therapies. These are not labeled therapies. These are not therapies which can be used anywhere on earth. And you can tell a patient, oh, I'm going to give intralipids and 100% you will have a successful outcome. Never. Please remember, successful outcome is actually a crosstalk between a euploid embryo and a normal endometrium. Okay, once this euploid embryo and normal endometrium have this crosstalk with each other, only then at the molecular level these things will work. If you have an aneuploid embryo, the crosstalk is going to fail, and upregulation and downregulation of the genes in the endometrium will not be able to sustain an implantation, which is why you may have a biochemical pregnancy. Okay, but just keep this in mind, because when you try and look at therapeutic options, and when you look at and when you want to explain this to the patient, this is important. Because currently what happens is, one IVF cycle fails, they will say, oh, one IVF cycle has failed, now we should put intralipids. It's not going to work. One IVF cycle has failed, oh come on, let's go and do LIT. No. One abortion you have, oh very good, now you have one abortion, I will put IV immunoglobulin. All these things are commercial businesses. That has got nothing to do with science, because such type of foolish things will only happen in India. You will not be able to do any of these therapies at any other place as soon as you cross Indian borders, because majority of these therapies are unlisted and unlabeled, and we have to use them very, very carefully and sparingly, which should be the take home point of immunology.
Yeah, yeah. So, see, all this we are discussing and talking, it is only to have, I think, relevance of the treatment aspect, as you told. So, in your practice, I mean, what is your take on, like, when are you going to even consider that immunology is something which this
We will
patient
come
may
to
need?
that in our next session, as to
Yeah,
when
yeah,
to consider an immune therapy in any of these patients. We'll come to that in the next session, madam.
yeah. I think then we'll wind this up. You
Yeah.
show the hysteroscopy. Yeah. Okay. Thank you so much.
Okay.
I think this was wonderful basics. So we'll go on with these sessions this whole week. So I request all the members to attend in continuity so that the whole topic gets covered and it will be making more sense to all of you. Thank you.
Thank you, madam.